Welcome to everybody to this ventilation and aeration and perfusion session this morning, early in the morning. It's my pleasure to chair this session with Professor Van Haren from St. George Hospital in Sydney, Australia. I remind to all the speakers to stay in time for 15 minutes so we have time for discussion. We have to strict finish for the poster awards ceremony. It's my pleasure to invite the first speaker, which is Lorenzo Ball from Genoa. We'll talk about ventilation and perfusion are both important in hypoxemic respiratory failure. Lorenzo.
Good morning to everyone. Thank you for the presentation and thank you to the audience for being so early here to attend this session. Can I see my slides, please? I have the remote.
Yes.
Good morning again. I have no...
There is any problem from...
No, it's working now. It's working now. Good morning again. We will talk about the importance of ventilation and perfusion in respiratory failure. I have no disclosures for this presentation. Well, in the last years, we probably somehow rediscovered the importance of lung perfusion in determining the gas exchange impairment. And this field of research has been surely boosted by the COVID pandemics, in which since the early times we realized that loss of aeration alone was not able to explain the severity of gas exchange impairment, especially in the patients in the earlier phases of the disease, where ground glass lesions predominate, and the severity of gas exchange impairment can be extreme, also to levels in which normally we had seen a lot of non-aerated tissue at the CT scan in respiratory failure from causes other than COVID-19. So it's not that the topic is new, it's decades that researchers claim and insist on the importance of perfusion in understanding the pathophysiology of respiratory failure, but somehow we were forced to rethink to this topic, and the research has been boosted in the field. So when we think about the mechanisms of mismatch between ventilation and perfusion, we go back to very classical studies and models. Of course, we are all familiar with the VQ distribution plot, which is illustrated in this slide. On the right side, you see an example of 3 respiratory units. The one on the left is reached by blood flow, but not reached by ventilation, and this acts as shunt, which corresponds to the black dot on the left part of the VQ distribution plot, while the middle alveolus receives matched ventilation and perfusion, resulting in efficient gas exchange, and this corresponds to the peak of the bell-shaped distribution of the VQ distribution plot. And on the right side, we see an alveolus which is not reached by perfusion, but is ventilated, and this corresponds to the black dot on the right side of the graph. So, while we are all very proactive in identifying mechanisms of loss of aeration, we are very used to investigate it with the conventional radiology techniques. We are much less accustomed to think about the perfusion compartment, which might be affected by vasoconstriction mechanisms, which are somehow protective in several contexts. Possibly also vasodilation. It has been long discussed whether the ground glass lesions in COVID were hyperperfused. Also, endothelial swelling is another mechanism capable of altering the flow inside the pulmonary vessels, and also the presence of blood clots. and the mechanical compression of the pulmonary vessels performed by the application of positive pressure within the alveoli. And all of these features are also, of course, influenced by the changes in the cardiac output and the overall lung perfusion. So, things are complicated. We can try to make them a little bit simpler, defining mutually exclusive aeration and perfusion compartments within the lung. And if we compare such compartments, so dead space, shunt, high VRQ, low VRQ, it's quite straightforward translating them into the VRQ distribution plot that we have seen before. Essentially, the shunt, again, is the black dot. The yellow part is contributing to venous admixture and is characterized by a low VRQ ratio. The right part is characterized by high VRQ ratio and wasted ventilation, with the extreme being dead space. But we have a fifth compartment, which not all the imaging techniques are able to identify, which are areas which are neither ventilated nor perfused. To some extent, this might be protective towards the worsening of hypoxemia, because we exclude one part of the lung which is sick from the perfusion. But one thing that we should keep in mind is that if we define in a mutually exclusive way these compartments, the sum of these compartments must be 100%. So however we manipulate the physiology of the lung, whether changing ventilator settings, changing patient positioning, giving drugs, we never act on a single compartment, but we carry the risk of diverting the cardiac output towards regions of the lung characterized by other types of impairment of the ventilation perfusion matching. When we use imaging techniques that were invented by the radiologists, we sometimes face problems because we share the same techniques, but not the same goals. Typically, radiologists are looking for anatomical and morphological changes in the lung, while we are interested in looking at the lung in a functional way to understand why the gas exchange of our patients are impaired. This is the classical VQ scan, bidimensional. That was the gold standard for VQ assessment for a long time in terms of imaging, whose natural evolution is its three-dimensional update made with single positron emission tomography. These images, which are represented in yellow, can be easily co-registered with the CT scan images. But again, what the radiologist looks for in this scan is, again, the presence of a clot inside the pulmonary vessel corresponding to an area of hypoperfusion, and it's probably not enough for our goals. From a radiologist's point of view, the interest towards this kind of scans has declined over time after peaking a couple of decades ago, and this is paralleled by a steep increase of the prescription and the request also from the intensivist side of computed tomography, contrast-enhanced CT scans to detect macroscopic pulmonary embolism. And that's the main reason why these kind of exams are performed. But that's not what we want in our critically ill patients. There's one imaging technique which is totally in our hands, which is EIT, which is finally a bedside tool that allows us to assess simultaneously ventilation and perfusion. There are several studies on the field. For example, in this interesting study, which is not shown in the slide, but now it is, the authors compared the ventilation and perfusion maps and overlapped them in order to identify which regions of the lung only received ventilation or only received perfusion, which are represented in blue and red color in this plot. The authors in this paper just published on critical care observed that the extent of ventilation-perfusion mismatch was associated with the mortality in critically ill patients with ARDS. That's interesting. I just want to spend a word of caution about EIT. It's a bedside tool. Finally, we have the opportunity to see in real time what we do to our patient, and this technique is characterized by a high temporal resolution, meaning that we have information moving over time, and we can see immediately the effects of our physiological manipulation of the lung. However, the spatial resolution is rather low, and this is a call to paying attention when very complex and sophisticated regional analyses are performed based on such a low resolution data. The matrix from which most EIT machines derive the measurements is just 32 times 32 voxels. Just a comparison, this icon, which appears in your modern smartphones, has a resolution of 160 times 160. So all we know about lung ventilation and perfusion from AIT stays in the small square box as compared to the resolution of modern mobile phones. Moreover, perfusion depends on how you look at it. For example, in this study using positron emission tomography, perfusion was redistributed in the ventral to dorsal gradient according to the patient positioning from supine to prone. So changing position might influence perfusion, but when I say that perfusion depends on how you look at it, I also mean that choosing a different imaging technique might give different results, and this is quite an alarming finding. When we want to measure the same thing and just choosing another technique, we get different results. We must ask ourselves, what are we really measuring? For example, in this study we conducted in Sweden, in Uppsala, we observed that regardless of how PEEP was set, on the left side you see a low PEEP setting strategy, on the right side an open lung approach, while the ventilation was redistributed, perfusion was not, so partially contradicting the finding of the previous study. And this finding is confirmed by several other research groups. So what happens to perfusion? It's complicated to assess and sometimes depends on the technique we choose to assess perfusion. Of course, perfusion also depends on the type and extension of lung injury. For example, in this experimental study in pigs, while before the induction of lung injury, there was a clear gravitational gradient of perfusion with more perfused area being towards the dorsal regions, and a clear gradient was observed. When the lung injury was induced, a sort of bell-shaped distribution appeared with no clear gravitational gradient. So, of course, the type and extension of lung injury influences how perfusion distributes in the lung. In this other paper from our group, we have looked with another technique, which is dual energy computed tomography, the distribution of pulmonary blood volume within the lungs of COVID-19 patients. And quite surprisingly, we observed a reverse gravitational distribution, possibly explained by hypoxic vasoconstriction in the dorsal region, and possibly also mechanical constriction of pulmonary vessels, which were compressed within the consolidation areas, in addition to the well-known problem of pulmonary coagulopathy, which affect ARDS in general and COVID-19 related ARDS in particular. Perfusion, of course, depends also on how you set PEEP. There are plenty of studies showing that using, for example, EIT. And again, in a sub-analysis of the same data set, we observed, the only concept I wanted to stress in this slide is that the amount of dead space that appears when we increase PEEP is not necessarily located in hyper-distended areas. We have observed a relevant amount of lung units acting as dead space within the ground glass. So expanding the alveoli through the application of positive pressure might have a cosmetic effect on gas exchange by diverting flow away from the ground glass regions, with unpredictable interaction with the endothelial inflammation and the procoagulative status of these areas of the lung. So to conclude, ventilation and aeration loss alone are not able to explain the severity of acute respiratory failure and gas exchange impairment in ARDS. Perfusion and ventilation must be matched, and assessing their mismatch is not easy, at the bedside especially. And lung perfusion is influenced by all the physiological manipulation we perform, both on the respiratory and circulatory part of the heart and lung interaction. So in conclusion, in ARDS, both ventilation and perfusion are important. Thank you.
Thank you, Lorenzo. Any questions from the audience? So, just briefly, so this data suggests that gas exchange per se alone may be misleading in the classification of different types and severity of hypoxemic respiratory failure, and also misleading in the interpretation of changes in gas exchange with different type of ventilation?
I think that the inadequacy of gas exchange alone to assess what we do in our patients is one of the few topics on which most of us would agree. It's a matter also of perspectives. This is also only just another thing to think about, that when we change ventilatory settings, the lung is affected differently depending on many factors regarding both ventilation and perfusion, and looking at improvements in gas exchange alone might be also misleading in some cases, in which we think we are gaining advantages, but we are actually potentially worsening some of the mechanisms. I'm not saying that we should not use PEEP in a patient with, for example, an initial COVID disease, and we have clinical data showing that this improves oxygenation and in some cases also the final outcome. But it's just a call to take into account all the different mechanisms that play a role in determining the final gas exchange, and not just being happy of seeing that the saturation increases or that the carbon dioxide decreases.
One last question. Thanks for an excellent talk. So perfusion in COVID ARDS compared to perfusion in non-COVID ARDS, how does that compare?
Well, there are relatively few studies directly comparing perfusion in the two causes of respiratory failure. But after all, I think that the main issue is that ARDS is a very heterogeneous group of diseases. Probably we just had the chance of focusing on a very homogeneous group of respiratory failing patients sharing the same pathophysiological mechanisms, and who knows which surprises we might have if we have the chance to investigate separately, not COVID versus ARDS, but within ARDS, all the different pathophysiology that can be behind such syndrome.
Thank you very much again.
Thank you.
Then it's my pleasure to introduce the next speaker, Domenico Luca Grico from Rome, Italy, and we're going to hear about respiratory mechanics and recruitability. Thank you.
Thank you, Mr. Chairman, and good morning, everybody. In the next few slides, I will try to deal into the importance of respiratory mechanics and recruitability in patients with acute respiratory distress syndrome. So, these are my conflict of interests. And I will start from basic physiology, stating and trying to address which are the objectives of mechanical ventilation in patients with ARDS. So we know that we have to provide some kind of oxygenation. We know that we have to provide some kind of CO2 removal to maintain pH within physiological ranges. And in the last years, in the last 30 years, we really learned that the main objective of mechanical ventilation in ARDS is to maintain gas exchange while reducing the risk of ventilator-induced lung injury. Most of the deaths in ARDS patients are caused by the consequences of ventilator-induced lung injury. And in this context, assessment of respiratory mechanics may allow to personalize the intervention on tidal volume, respiratory rate, and PEEP to minimize the risk of ventilator-induced lung injury. So, the most important aims of respiratory mechanics is to monitor this aspect during mechanical ventilation to establish which is the upper limit of ventilation and limit the risk that the ventilation that we provide to the patient to maintain gas exchange causes excessive stress and strain. Stress is the amount of pressure that is provided to the lungs, while strain is the mechanical distortion provided by tidal volume in the aerated lung that we all know it can be markedly reduced in patients with ARDS. And to assess stress, we should have actually transpulmonary pressure, because the definition of stress is that the total increase in transpulmonary pressure from a resting condition, so from a situation in which the set PEEP is 0. But what we commonly do in clinical practice, and I think that works to assess stress, at least in non-obese patients, is to measure plateau pressure. In this tracing, you see, this is volume control mode. The first tracing is airway pressure. The second tracing is flow. The third tracing is esophageal pressure that we use as a surrogate of pleural pressure, but we actually do not need these for measuring plateau pressure. Just measuring plateau pressure is really important because in most cases, so in a number of patients that are not obese, plateau pressure is very informative about the total stress that we are providing to the patient. This is really easy to do at the bedside and should be part of our clinical practice, because keeping plateau pressure below 28 or 30 centimeters of water should be seen as a priority in all ventilated patients. Indeed, if we want, we can measure also transpulmonary pressure and to assess the total stress. We have learned that transpulmonary pressure can be calculated in 2 ways, because transpulmonary pressure is informative of the regional transpulmonary pressure in the lungs, as transpulmonary pressure is not constant across the lung tissue. It is more positive ventrally, it is more negative dorsally. And if we calculate transpulmonary pressure as a direct difference between airway pressure and esophageal pressure, we know we can measure the transpulmonary pressure that is in the part of the lung that surrounds the esophagus, so the dorsal part of the lung. But actually, the part of the lung which is exposed to the risk of ventilator-induced lung injury due to excessive stress is the anterior part, which is called the baby lung, so the most ventral areas that are ventilated. And a couple of years ago, with a large group of investigators, we demonstrated that actually it is possible to calculate the transpulmonary pressure in these ventral areas, and this represents the stress, and this can be calculated with a simple formula from the elastance ratio of the lungs to the respiratory system. Essentially, when you multiply airway pressure times the ratio of the elastance between the of the lung to the respiratory system elastance, you obtain a value of pressure that corresponds to the transpulmonary pressure in the anterior part of the lung. This takes essentially the message that to limit stress, it is mandatory during mechanical ventilation to maintain plateau pressure below 28. And if you have esophageal pressure, it is possible to be even more precise, and we should target a plateau transpulmonary pressure which is below 23 centimeters of water. This corresponds to a threshold over which the risk of lung damage increases exponentially once you increase pressure. And this is what we mean by protective ventilation in terms of reduction of stress. But stress is only a part of the aspect, because this is an intensive force that acts on the lung, while the other big determinant of ventilator-induced lung injury is the concept of strain. To make it simple to understand, I put the CT scans of 2 patients who have the same height. So they are 180 80 centimeters tall, 2 patients on the right and on the left. So if you set tidal volume based on predicted body weight, you would end up setting the same tidal volume in these 2 patients. But the difference these 2 patients is relevant because despite having the same height, these 2 patients have a different size of the baby lung, of the ventilated lung. So if you set the same tidal volume in these 2 patients, you will make the ventilation more injurious in the patients in the right side because the lung is smaller to receive the tidal volume. And this is the concept of strain, so the amount of volume that is inflated normalized to the size of the lung that receives this tidal volume. So strain is calculated as tidal volume divided by FRC, or functional residual capacity. And obviously, it's not very simple to measure FRC at the bedside. We have tools to do so. EIT could be a solution. We have gas dilution on some ventilators to measure lung volumes. But luckily, thanks to the concept of the baby lung, we actually understood that the size of the aerated lung is very strictly correlated to respiratory system compliance. Respiratory system compliance is very easy to measure at the bedside because you take the tidal volume, you take the driving pressure, which is the plateau minus PEEP after you measure plateau pressure, and the ratio of tidal volume to driving pressure is the respiratory system compliance. And respiratory system compliance is tightly correlated with the size of the aerated lung that you are measuring. And this is very interesting because if the dynamic strain is the ratio of tidal volume to FRC and the respiratory system compliance is very close to the FRC, the ratio of tidal volume to respiratory system compliance would be a very good estimate of the dynamic strain. And this is the driving pressure, which is what we can measure on the ventilator to estimate the strain. This is why we have a wonderful study to show this concept in a large clinical population. In this large study led by Marcelo Amato, we clearly showed that the effect of tidal volume on mortality, so reducing tidal volume on mortality, is fully mediated by reduction in the driving pressure. So if you see here, you clearly see that the effect on mortality in the bottom of reducing tidal volume that do not exist when you consider solely tidal volume normalized to the predicted body weight, but is profoundly relevant once you consider tidal volume scaled to respiratory system compliance, which is the driving pressure and which is an estimate of strain. And this is confirmed also in terms of effects on mortality by big changes. If you see that a threshold of safe, we do not have a threshold of safe driving pressure, we can say that above 14 centimeters of water, there is an exponential increase in the risk of mortality in patients with ARDS. So the second clinical message could be that it is very wise to reduce tidal volume if plateau pressure is not high, but the driving pressure exceeds 14 centimeters of water, because this means that we are providing excessive strain. One question that I really raised in some other sessions, and I included in these slides, is whether or not these concepts of driving pressure and compliance to estimate strain, respectively, lung volume and strain, are reliable in patients with COVID-19. We measured lung volume in these patients, and we actually see that, yes, also in COVID-19 ARDS, at least in the early phase, the respiratory system compliance is tightly related to the lung volume that we are ventilating, and the dynamic strain is tightly related to the driving pressure. This is true at PEEP 5, but it's not true at PEEP 15. So the suggestion, if you have to, if you want to have an idea, an estimate of strain, is to measure the compliance of the driving pressure at PEEP 5, and these are a good estimate of the size of the baby lung and the entity of the strain that we are providing. Unfortunately, I'm just mentioning this, sometimes we think that when we change PEEP, we can assess recruitability with assessing the change in respiratory mechanics, especially driving pressure and compliance. This is not the case. We have data to show this. So if you see these two slides, you see that there is absolutely no relationship between the change in compliance that you produce with an increase in PEEP and the change in the driving pressure that you produce by an increase in PEEP. There is no correlation with the change in dynamic strain produced by this change in PEEP. So I would say that there is no reason why compliance and driving pressure can be really used in the single patient to assess the effects of PEEP, and they can be quite misleading. But driving pressure and compliance are only one part of the problem, together with plateau pressure. And also, we have learned that also the rate in which driving pressure is delivered to the patient should be taken into account in this analysis done by a large group of investigators led by Marcelo Mato and Eduardo Costa. They actually tried to assess the respective effects of high driving pressure and high respiratory rate in patients with ARDS. The idea is that if you reduce driving pressure by reducing tidal volume, you will need to increase respiratory rate to maintain CO2 within a safe limit. And they tried to address whether this is convenient or not, because otherwise you would go down with the tidal volume to an extreme condition. And what they actually show is that both increases in driving pressure and increases in respiratory rate are injurious. And this is because the driving pressure represents the reduction in the lung volume and the aerated lung size, while respiratory rate corresponds to dead space. So these are the two main pathophysiological mechanism driving acute respiratory failure. One is aeration loss, the second one is vascular disease in ARDS. And what they found interesting is that they actually both respiratory increases in respiratory rate, and increases in the driving pressure are injurious, but the increase in the driving pressure for 1 centimeter of water is really 4 times more injurious than increases in respiratory rate. To make a simple example and go to my conclusion, if you take this patient that starts from, you see a tidal volume 400 and a driving pressure of 15 with a respiratory rate of 16 and a respiratory rate of 30, well, in this case, it is convenient to reduce tidal volume to go to 15 of the driving pressure and increase respiratory rate. In this other patient that starts from 400 milliliters and 8 of driving pressure, there is no reason to reduce tidal volume and increase respiratory rate. This would be injurious and should not be done. This takes to my conclusion, and this states that compliance is proportional to the size of the aerated lung, and it is better correlated if measured at low PEEP. Plateau pressure, better if measured with transpulmonary pressure, informs about stress. Safe limits for plateau pressure are 28-30 centimeters of water for airway plateau pressure and 20-22 centimeters of water for transpulmonary plateau pressure. Driving pressure is both the static stress and informs about lung strain, and it is sound to reduce tidal volume if the driving pressure exceeds 12-14 centimeters of water, but driving pressure should be always integrated with respiratory rate. There is no need to reduce tidal volume if compliance is high, driving pressure is low, and this yields to unnecessary increases in respiratory rate. Thank you very much.
Thank you for a very informative talk. Are there any questions from the audience? A bit hard to see.
Yes.
Yep.
This could be challenging.
Hi, Domenico. Thank you very much. Excellent talk. Can you explain again why you did not find a correlation between changes in compliance and changes in driving pressure and changes in strain? How did you measure strain in that graph that showed a bad correlation? But only at PEEP of 15, right? The change, sorry, it was...
So what... Okay, I cannot go back. So we tried to see if the... once we increase PEEP, the aim is to reduce strain. So reduce the amount of... You increase the aerated lung size, and you want to reduce the ratio between tidal volume and the aerated lung size. We tried to see if there is an estimate that works well to estimate the changes in dynamic strain produced by PEEP, and the change in compliance does not work. The change in driving pressure does not work. The change in oxygenation does not work. What is really tightly related to the change in the dynamic strain produced by PEEP is, for instance, the recruitment to inflation ratio that can be measured at the bedside with a simple maneuver. But this will be part, I think, of the talk of one of the following talks by Laurent.
I have two questions for you. The first one is related to transpulmonary pressure. You know that there is, most of us, we agree that the changes, so the difference between inspiration and expiration in transpulmonary pressure is quite accurate. So when you measure the elastance of the chest wall and, of course, in relation the driving transpulmonary pressure. But there is more questions related to the interpretation of the absolute value of transpulmonary pressure. This due to the fact that there is a gradient that is not very clear if you have to correct or not this measurement. So first question is, what's your approach in the calculation and interpretation of the absolute transpulmonary pressure, first? And the second related to the strain. Because I'm always a bit confused about the concept of strain. We know that it's tidal volume divided the volume, the aeration of the lung. My feeling is that the strain was proposed for normal physiology. What I mean, that you expire at a certain level of pressure, so atmospheric pressure, and then whatever changes volume that you have is related to the volume that we have actually now. Our patients have a completely different situation because we manipulate the end-expiry volume by pressures. So at that point, I'm more confused to translate the concept of strain in a sort of end-expiry lung volume, as you showed, at low level of PEEP in our condition, and when you apply the PEEP, because you manipulate the end-expiry lung volume in an artificial way, and so you artificially change the denominator. So, and that's probably explain your findings in which you had problems the model did not fit what we have in mind when you increase the PEEP. So just to open the discussion about the concept of strain.
Okay, starting from the esophageal pressure, I think we have data showing that the absolute value of esophageal pressure reflects the pleural pressure in the lung areas that surround the esophagus. So when we measure transpulmonary pressure as airway pressure minus esophageal pressure, we are aware that this refers to the transpulmonary pressure in the dorsal part of the lung. So it could be used to maybe to set PEEP. We have some data showing that maybe targeting a zero value of transpulmonary pressure calculated with this direct measurement could be beneficial in patients, but I think that randomized trials should be carried over. Regarding strain, I definitely agree with you. The original papers were obviously taken at 0 pip to solve this issue. What we try to do is just to consider that the actual strain, dynamic strain, should be at 0 pip. It is obviously tidal volume divided by FRC. When you apply PEEP, we include in the denominator the amount of alveolar recruitment. So if the calculate recruitment, you can increase the aerated volume. So the strain that, in my mind, this strain is represented by tidal volume divided the functional residual capacity at 0 pip plus the amount of recruitment that we obtained with PEEP. And this was done for that, and I think there are other mechanisms that are driving the lack of correlation, but indeed the point of interpreting strain once you change PEEP is quite complex as well.
One final question. If you look, for example, at COVID and the evolution of COVID in patients, it's very different early on. Their dynamics, their compliance, compared to maybe a patient who's been on a ventilator for 3 or 4 weeks. So how does that affect your equations and your measurements in terms of driving pressure and strain and stress?
I think that the relationship between, I think, compliance and lung volume exists at the beginning of the disease, as in all other ARDS. I don't think there are measures, such detailed physiologic measures for end-stage diseases. For sure, we know that patients with COVID-19 may hesitate in having a very low compliance. Also, those patients that are ventilated with prolonged NIV, for instance, so old COVID-19 may end up having very low compliance. Maybe in that case, compliance partly depends on the reduction in lung volume caused by the disease, but also takes into account a part of fibrosis that could be contribute to the reduction in increase in elastance and reduction in compliance. But honestly, I have no doubt that it could be something to address in these patients.
Thank you very much,
Thank you,
Domenico. And now is our pleasure to invite Marcelo Amato to talk about how to make recruitment maneuver safer and more beneficial.
Good morning, and thank you, Mr. Chairman. So I'm not going to talk precisely about safety, but much more of how to be sure that we are measuring it correctly. I think this paper recently published, and I think that was led by Golliger, was showing that changes in oxygenation, so the response, taking the data from the PEEP trials, high PEEP trials, and the benefit or the harm appeared. So when you increase PEEP, so there was 2 hypotheses that how you can understand that PEEP is beneficial, by looking at oxygenation or by looking the change in compliance or changes in driving pressure. And it was clear that you should look at mechanics because oxygenation does not correlate, the response in terms of oxygenation does not correlate with the benefit of PEEP. So this was very clear in this retrospectively post hoc analysis, and this gives us the concept that when we try to assess if a certain change in PEEP was beneficial or not, we should look at mechanics. The same information was confirmed in the alveoli trial. So Laurent Brochard has
proposed this very interesting maneuver to assess recruitability looking at mechanics. How it works. This is an example of a patient. So in the upper panel, so we don't have a good pointer. But anyway, in the upper panel, we have airway pressures, and then we have a step changing PEEP, 6, 16, and 6. In the lower panel, we see the response of the EIT plethysmograph. And as you can see, at a certain point here, we decrease the respiratory rate, and this is important to not have any auto PEEP. And then you suddenly decrease the PEEP level, and then you observe that, okay, my change in PEEP is 10 centimeters of water. My change in end expiratory lung volume, so this is the plethysmograph of EIT, so it's very well correlated with lung volume, is 1,000 mLs. So the question is this change in volume proportional to what is expected for that PEEP change? And you have to take into account compliance. So for instance, if compliance is 30, I should expect that by changing 10 centimeters of water, I should have a change in volume of 300. However, I observed 1,000. So there is a difference of 700, which must be correlated to the recruited volume. And once I removed PEEP, this recruited volume collapsed and was captured as an exhaled tidal volume out of proportion to my reduction of PEEP. And this is why Laurent proposed this index. How much is the non-proportional change in volume divided by the expected change in volume, 700 divided by 300, and then this is 2.3. So if the patient does not have any recruitability, the number should be 1. Or, yes, or in fact, sorry, it's going to be 0, because it's going to be 0 divided by 300. But any number that is above, for instance, 0.5, means that at least half of the change in volume was caused by recruitment. If the number is 1, is that, okay, let's say it's because you have 300 expected according to the compliance, and 300 non-expected because it was caused by the collapse of the recruited areas. So a number above 1 means that you have a lot of recruitability. And Laurent, in his paper, proposed a cutoff of half, 0.5. This number came just because it was the median value, but we don't have yet a good study to say that 0.5 is a good cutoff to say that the patient is recruited or not, recruitable or not. And then using EIT, we have been looking for these concepts and trying to understand a little bit better. And what we have proposed in the last years is to do a stepwise increase in PEEP and then a decremental stepwise maneuver again, very symmetric. In the bottom part, you can see airway pressures, and in the upper part, you can see what happens with the plethysmograph with EIT, which represents lung volume. And as you can see, for instance, at the same PEEP level, for instance, I started with 5 of PEEP, and I'm increasing 5 by 5. So at 15 of PEEP, my lung volume is like this dotted line. And then when I'm at 15 of PEEP again, but now in the descending part of this curve, I can observe 2 things. First is that my end expiratory lung volume is not the same any longer. It's much larger. And also, the swings in lung volume, and I'm using pressure control ventilation, are much larger too. So I have 2 things happening at the same time. I have an increase in FRC, and I have increase in dynamic compliance. And for instance, putting one on top of each other, so in red you have airway pressures, in blue you have the plethysmograph of the EIT. This is an example of a patient that has reasonable recruitability. This is a patient with very high recruitability, so the changes in the plethysmograph are out of proportion, are much larger than expected by the change in airway pressure. So this is a typical recruitable patient, and this is a typical non-recruitable patient. So you almost do not distinguish the changes in airway pressures from the changes in the plethysmograph. And we can do a little bit more fancy calculations because then we can put in a kind of mathematical frame. So if I take each step of this maneuver, I can plot this maneuver in a pressure volume plot like this. So this is, in the Y you have volume, in the X you have pressures. So if I take, let's say, this first step, I can plot it here like a kind of slope and a compliance chord. I take the next step, and this is, so the slope of this segment, the blue segment, is going to be the compliance at this moment, right? If you take the next step, you're going to have another segment, and you can also compare in multiple steps what happens with compliance. In this case, not a big change. But if I take, for instance, another example, I see something very interesting because I see that I see in the next step an increase in volume, and now this new segment is not a continuation of the previous one. This means that I had a jump in lung volume precisely because I got some recruitment. This is the gain in volume that is calculated by the recruitment to inflation ratio, is this vertical displacement in the pressure volume curve, and so forth. So this is a real case of a patient, and we can see that at a PEEP of 10, I had this kind of segment, and then at a higher PEEP, for instance, 25 in this patient, I had this very big displacement. But look at the slope of this curve. The slope of this curve is much lower than the slope at the beginning of the curve. So it's interesting that I had a big increase in lung volume, but not an increase in compliance. In this case, it's a typical result of a non-recruitable patient. They are simply following the same exponential, right? So there is a negligible increase in lung volume, while in this case, I had a very big vertical displacement. And something that, for instance, you can compare. Look what is happening at a PEEP of 15, and then again at a PEEP of 15, after the recruiting maneuver, I have two things happening here. I have a vertical displacement, which means non-proportional gain in lung volume. That was not expected, so this is a recruitment, it's not an inflation. And, and I see at the same time that the slope is larger. So in this case, I can see there is a gain in lung volume and gain in compliance. I will come back to this point because this explains a lot the findings of the previous talk. What I want to say is that when you have a recruitment, you can have both. You can have an increase in lung volume or an increase in lung compliance, or you can have both. But it's not guaranteed that you are going to see always a change in lung compliance and always a change in lung volume. And I'm going to explain why. So if someone can give me a pointer would be very nice, because this talk without a pointer is very difficult. So these maneuvers are so useful at the bedside that some companies now have proposed to have an automatized recruitment maneuver at the ventilator. I like this concept because if you automatize, you program, let's say, the steps, And then you can focus your attention on safety. And now many different companies are doing this. This is just one example. You program the sequence of steps of PEEP that you would like to use. Typically, we do during pressure control ventilation to increase safety. And then you observe the gain in compliance. So the very bottom part of the curve here, we can see the changes in compliance in real time. So you can see the compliance decreased when we started to increase PEEP, but suddenly had this big surge, meaning that this patient was very recruitable. And in this case, compliance just dropped down if you look at this bottom part of the curve. You can also assess this by EIT at the same time. But look at this famous histogram that we can obtain by using CT. So in the blue, I can see the patient when, so at the same PEEP level, the two curves, they were obtained at the same PEEP level, before and after recruitment, okay? So the blue is before, the red is after. So look how many pixels I had here concentrated in the collapsed zone. So the density is below 100 Hounsfield units, minus 100. So which means that all these pixels contained in this area, they are collapsed. And then when I recruited, they jumped to this region. Because you can see that there is the initial, these pixels in blue, they do not exist any longer in the red curve. What does it mean? Is that all these alveoli, they got inflated, and now they got inflated to minus 400 density, which means that they started to have a small volume. They are not any longer completely collapsed. When this happened, I have a big compliance gain, always. Because they were completely non-functional and suddenly they have an intermediate volume in which they have the best compliance because they are in the intermediate part of the PV curve. Take this another example. Again, blue is before recruitment. Red is after recruitment. But now, the pressures I'm applying in the system, they are very high because this patient has very sticky atelectasis, so I have to apply very high pressure to recruit. And what happens in this case? So the alveoli that were initially collapsed, they are very few, and when they get recruited, they jump to this region in which the Hounsfield units is around 700, so they are already very well inflated. And for an alveoli that has a little bit of, let's say, thick septum, to get to minus 700, it means that it's already very overdistended. So the situation is completely different because I jumped from a completely non-functional status to, boom, completely overinflated status, which means that these alveoli, they gain a lot of volume, but they do not gain compliance. Because they jump completely from collapsed, non-functional, to completely overdistended, or again, no function. So they have a lot of air, but no compliance. And finally, you can have an intermediate situation, like this. Then you gain a little bit of compliance, a little bit of volume. So it depends pretty much on the pressures you apply to recruit and how much PEEP is your challenge. If your challenge is very high, very likely you are going to gain a lot of volume and very little compliance, and vice versa. So I have three different situations here. In the first one, I gain a lot of compliance, and these are real examples from patients. In the first one, I gain a lot of compliance. Just to give an idea, the gain in compliance was Sorry, the gain in compliance was 95%. So I almost doubled the compliance. And the gain in volume was very low. If I compare with this last one, I gain, in terms of compliance, I gain only 9%, but I gain a lot in terms of lung volume because of this big jump in lung volume. So 500 mLs of gain in volume. And then I can have an intermediate situation. So, summarizing these findings, the recruitment to inflation ratio measures only one of the two effects of recruitment, the aeration gain. With EIT, it is possible to compute both, the aeration gain and the gain in compliance. And if you compute both, you are always, you can compose them mathematically. It's a little bit complicated, and I'm not going to explain here, but at least you are always tracking some change in recruitability of the lung. And this is why if you look only at compliance, you don't observe the whole picture, and if you're looking only at lung volume, you're not observing the whole picture. So, when we do a correlation between the recruitment to inflation ratio, which is looking only at the gain in lung volume or the increase in FRC, and this complete assessment of recruitment by CT or by EIT, you have a reasonable correlation, which means that these indexes, they can be used at the bedside. But they are not perfect as expected because they are precisely proposed as a practical tool. But I think this explains a little bit of the findings that Domenico was talking about, that sometimes, especially when you're applying a high PEEP, the changes in compliance are not proportional to the changes in lung volume, and this is why exactly he found a bad correlation. Because the alveoli immediately jumped from a completely collapsed position to boom, overdistended and not any longer with a good compliance. So, I participated in this initiative that was led by Laurent Brochard, the recruit protocol. So the picture is in our ICU is already kind of representation of the maneuver. And we are trying to have more data in more than almost 200 patients in very different ICUs around the world using EIT and collecting data. So this data, I'm very grateful to Annemine and Glaziella that they provided me with this data. They did the hard work. And so in this maneuver, we are trying to assess both things. So the recruitment to inflation ratio in patients, you can see the whole sequence. And then a complete maneuver in which we can assess the whole recruitability. How much time I have? I'm a little bit lost.
Minus 2 minutes.
Oh, okay, so I'm going to finish. So then I'm going to finish here. So as you can see here, we can, if you have the complete picture, it's like having a CT. So you can know very well how much the patient is recruitable. And then I can make a cutoff, like patients can be non-recruiters when they had less of 25% of the units in the lung recruitable. And then the recruiters, when they have more than 25% of the lung that can be recruited. So the two columns. And then you can see here that the RI index, the ventilator to inflation ratio, proposed by Laurent Brochard as a bedside tool, has a good discrimination between the two situations. You can see that you can calculate this just using the ventilator without using the EIT, or by using EIT, recalculating what the information you get from the ventilator. And in both situations, they are in the two lines below. You have a good discrimination. They are not perfect, but they are good enough for bedside purposes. But maybe this data is suggesting that we should use a little bit different cutoffs. And my proposal here is that the cutoff should be based on the change in driving pressure that you can obtain at the bedside. To say that a patient is recruitable or not, I think it makes sense to concentrate in the mediator of ventilator-induced lung injury. And we should define this according to the consequent change in driving pressure that you can achieve if the patient is recruitable or not. So, and according to this concept, my proposal is that, okay, a recruitable patient is a patient that can get at least 2 centimeters of water reduction in driving pressure after a big change in PEEP or any bedside maneuver. Thank you very much.
Thank you, Marcelo. Any questions from the audience? Yes, please. We have time for one question.
Thank you, Marcelo. So I have just one question, maybe something to fine-tune, maybe even more, because we know, of course, we know very well that the recruitment maneuver, I mean, how much you recruit is a matter of the critical opening pressures. So the plateau pressure, when we increase people, what we're doing, we're increasing plateau pressure, depending how much we reach the critical opening pressures of some units, we open them. So I fully agree with all this method, I really believe in that. But I still have this concern about what's the maximal pressure, because like if you do 16, 6, the plateau pressure with 16 PEEP, you'll be something maybe below 30, below 35. Maybe you decide that patients not recruitable because you just did not reach some critical opening pressures. So I think it's very important that you should, I would like to ask you, when you propose this, there's some algorithm to see what's the maximal plateau pressure that you decide that patient non-recruitable. Because the response will be very reliable, but for that pressure you apply it. Maybe a patient that needs 45, 50, if you never apply that, we always say is non-recruitable, but it was because you did not apply the pressure that many units of that patient needed.
This is a very good question. So I think it's more or less like this. So to assess recruitability, should we recruit all the patients and then look backwards? It's a kind of paradox. And then the idea is that can we have a kind of screening maneuver to understand if it's worth to go on and to move on for higher pressures? And we are trying precisely to get this information, and this is why at the end, all patients, they suffer of the most aggressive recruiting maneuver that we can think it's safe. And then we are comparing to see if there is a progression. And then if we get already a good signal, just going to 16 or to some level, that can give us the picture. And let's say the preliminary information we have is that there is some correlation. It's not perfect. And it's a very good correlation when the patient has a diffuse disease, because then the recruitment is progressive. But when the injury is a little bit focal, then sometimes let's say the screening maneuver doesn't work.
Thank you very much. We have to move on to the next speaker. And it's my pleasure to introduce Laurent Brochard from Toronto, Canada. We're going to stick with the same topic, measuring alveolar recruitment, and Laurent is going to tell us why and how. Thanks.
Thank you so much, Mr. Chairman. So I hope you're ready for another dose of alveolar recruitment. My objective in general is try to make these complex concepts accessible at the bedside. So I'm going to give you the subtitles for Marcelo Amato's talk. So Marcelo, thank you for introducing the principles. My laboratory has been working with a number of companies to get research grants or equipment mostly. And I think physiology at the bedside, and especially respiratory physiology or cardiorespiratory physiology when we speak of mechanical ventilation, is in 2022 precision medicine. and we have tools really to assess lung recruitability in ARDS. So we know that there is a large variability in what we call the lung recruitability, and as you probably understood, there are many definitions of lung recruitability. So I often use this slide because you have the example of two patients where you have CT slice at 5 and 45 centimeters of water. And remember, every time you increase the pressure, you increase the volume, right? So lung recruitment is not increase in lung volume. It's reaeration of zones which were previously collapsed or non-functional. And when on the left, the increase in lung volume is only at the expense of the already open lung, you see how it squeezes the heart, right? Because you simply over-distend the lung which was already open, and that's why non-recruiter usually have very frank hemodynamic effects of increasing pressure. On the right side of the slide, you see a recruitable lung, recruitable patients, because you see that when you increase pressure to the same extent than the previous patients, then you, to a very large extent, reopen the zone which were white or non-aerated before. So this is not exactly what we think when we want recruitment at the bedside, because at the bedside, what we want to do is to recruit, but then to keep the lung open, right? This is still 45 centimeters of water. We are not going to ventilate these patients at 45. And maybe to illustrate that, this is a beautiful slide from an experimental study. It was in the first edition of the Handbook of Physiology, so it's not anymore in the handbook, but if you want it, I can sell it for I can provide this is beautiful because you have at the same time, at the bottom, the pressure volume curves, the mechanics, and on the top you have the visualization of the lung. Okay, so the top, you see the lung is completely collapsed. It's an excised ex vivo lung, if you want. So there is no chest wall, of course. And you see the first part of the curve is very, very flat, and the lung does not open, right? And after 8-10 centimeters of water, you see the lung reopening progressively until the extreme part where the lung is open. And then you have the deflation. And interestingly, the deflation shows that the lung is kept open for a very long time, until the very last centimeters of water. So the translation in terms of the mechanics, the pressure volume curve, is what Marcelo showed, is that for the same pressure, for instance, you can look at 8 centimeters of water, once you have recruited the lung, you keep it open to a large extent, which means you reach the same pressure than before, but you have much more volume. So this is the concept of recruitment which we would like to understand at the bedside. Usually, clinicians use oxygenation. And oxygenation, of course, has some relationship with recruitment. However, it has so many limitations, and we know since the early studies in the field of ARDS that one way to improve oxygenation is to decrease cardiac output, because the distribution of perfusion will go less into the non-aerated area. So it's an artificial improvement in oxygenation just due to cardiac output. And Peter Suter very early showed that PO2 can go up, but when cardiac output goes down, the oxygen delivery is decreased. So that's no benefit for the patient. So PaO2 has really many limitations, including the fact that 15 to 20% of patients with ARDS have intracardiac shunt, which complicate the interpretation. So other people look at compliance, but it varies so much depending on how you measure. Is it an inflation maneuver or deflation maneuver? Compliance is supposed to decrease with lung volume, so if you see no change, how do you interpret? Compliance can be improved by intratidal recruitment, which is something we would like really to avoid because it's opening and closing, opening and closing. And also it poorly reflects the whole lung. It's really mostly the dependent part. So really, we need something more. EIT, I agree with Marcelo, is a fascinating tool. For now, we have not the definitive way to assess recruitment, but hope it will come. I just showed this example with a study we did with Takeshi Yoshida because it's visually very attractive. In a few minutes, you see the first slice. So it looks like a CT slice, right? But it's not. It's only where the ventilation goes. And you see the first one, it goes in the non-dependent part because the dependent part is collapsed. So we increased the PEEP and then it was much more homogeneous. But the slice C is the next day. The patient has improved. We kept the same PEEP. And we had the surprise to see that most of the ventilation was going in the dependent part. So how is this possible? The only explanation at that time is that we now are over-distending the non-dependent part. So it was an incentive to say, oh, we need to decrease the PEEP. And we decreased, I think, from 16 to 6 to homogenize the lung. So there is really something attractive in that technique, especially looking at the regional distribution. However, we have ways to compute the collapse and over-distension. You need a reference value, which is usually high PEEP. But we still don't know where to place the cursor, right? This is a very nice study from Rotterdam, and they decided that they placed the cursor at the minimal collapse, which was quite a high PEEP, right? If you see on the right, it's higher than the high PEEP FiO2 table. So it's a bit arbitrary, right? You could decide that you want less hyperinflation. You could decide you want the crossing point. We don't know yet very well. So this is why we propose this index, which, thanks to Marcelo, has already been described to you, based on this hysteresis behavior of the lung. And we try to make something simple. So we decided to say, okay, how can we assess how much of the volume will go into the recruitable part of the lung compared to the baby lung? Because there is always a non-recruitable lung. And this was nicely discussed previously, depending on the pressure you use, okay? We are talking of using reasonable levels of pressure which look safe, because you can always go higher on pressure and always reopen more. So the question we are asking is, within the reasonable level of pressure, how can we distinguish if we mostly inflate the baby lung or recruit the recruitable part? So that would be on the CT scan, you know, the green would be the baby lung, the yellow would be the recruitable part, and the red would be the non-recruitable part. So we based our reasoning on what Marcelo already described, the fact that the volume which is trapped by PEEP, which is gained by PEEP, if you wish, can be, on the one hand, the inflation of the baby lung, and you can predict that by the compliance of the baby lung, and on the other hand can be the recruitable new lung volume. So we do a PEEP drop maneuver from 15 to 5, and we measure the expired volume. I'm going to show you that in a minute, in a very short video, to show in real time how you can do it. And then we subtract the inspired volume, and we compare this gained volume or trapped volume by PEEP to the predicted one from the compliance of the baby lung at low PEEP. So it's just a matter of calculation. So we made a web page to help with this calculation. So this web page is called rtmaven.com. It's accessible for free. Yes, please take picture. That's a good idea. And this, you will see a number of videos explaining how to do it. And this is the video. I hope it's going to work. No, it does not. Okay. Okay, so you have to look at the website to see it. You do the maneuver in 2 minutes. You make the respiratory rate low to be sure there is no auto-PEEP. You drop the PEEP in one breath and you measure the expired volume, and you compare automatically this expired volume to the predicted one by the compliance at low PEEP. I'm happy to discuss more if you need, but the only thing you need to be sure of is that your patient is completely passive. So to do the maneuver, it takes 2 minutes, but we sometimes give a bolus of rocuronium or paralysis to be sure the patient is completely passive. And this gives you a value which, as Marcelo said in our initial study, was going from 0. So 0, this is the ratio of the recruitable lung compliance to the baby lung. So 0 means nothing go in the recruitable lung. Your lung is completely non-recruitable. And it goes up to 2, sometimes 2.5 or even 3. And the higher it is, the higher is the amount of volume going into the recruitable lung. And the median was 0.5, and we say, okay, any patient, which was half of the patients in our study, with a recruitment to inflation ratio 0.5 or below, we do not need to increase PEEP. We will leave the PEEP as the lowest possible, the lowest acceptable, maybe 8, 10, maybe sometimes 12, but we would not try to increase PEEP. And all other patients, we can try to increase PEEP until you reach a safety limit, which may be a plateau pressure or other index. And on average, you see there was a good correlation between the response in terms of oxygenation. And of course, it's not an excellent correlation, because if it was excellent, we would not need this index. There was a correlation with the decrease in alveolar dead space. The higher the recruitment to inflation ratio, the higher the decrease. And there was also a correlation with hemodynamic response, because the patients who were recruitable had no change in blood pressure. The patients who were non-recruitable had change in blood pressure. Everything here was done between 5 and 15 of PEEP, and you may have different results if you go higher, but we thought that would be a very good start for most of the patients. And this index has been used repeatedly. This is just to show a study by Domenico Grieco on COVID patients compared to non-COVID ARDS, and you see at the very bottom right that the recruitment to inflation ratio on average is not different between COVID and non-COVID, but the most important information is that the individual response is all over the place, both in COVID and non-COVID. So if you think of all studies which compare the high PEEP to low PEEP without taking into account the recruitability, there is no surprise that this study could not show any benefit. Thank you very much, and I hope you will attend our mechanical ventilation course, online or in person, in 2 weeks in Toronto. Thank you.
Thank you, Laurent, for making a very difficult concept sound very easy. Are there any questions from the audience? There's one question there. Microphone, please. Thanks.
So, Laurent, thank you for this beautiful talk. As you know, we use this RNI ratio, but I have two questions. The first one is, in some situation, if it is a very short time doing this maneuver, it's really not really well tolerated. And the second problem is that sometimes we have a high occlusive pressure. And so at that time, how do you do this ratio, this maneuver?
So the first one, you really surprised me. We do that in all patients all the time. It's 1 minute, it's one drop. So you say it's not well tolerated?
In some patients, very severe patients, of course, is sometimes not really well tolerated with a decreased drop in saturation, and sometimes it takes a lot of time to move back to the previous
that's not
saturation.
my experience, but I'm sure it can happen, yeah. And your second question is about airway closure?
Yeah.
Yeah, so I didn't have time to go that. So the concept is that when we measure the pressure on the ventilator, we expect that this pressure in static condition, like when we do a plateau or an auto-PEEP, reflect the alveolar pressure. And that's true if the airways are open. However, to our surprise, we found that approximately 1/3 of patients with ARDS have airway closure, which means the airways are closed. Even if the lung is still inflated, the airways are closed at levels which are between 5 and 20 centimeters of water. And for instance, the sickest patients, the higher is this airway closure. And so you need to know that for measuring the driving pressure correctly and for doing this measurement correctly. So if you go to the webpage, you will see how to do that. It's also very, very frequent in obese patients. We found when BMI is over 35, it's more than 65% of the patients. And lastly, because we now use EIT, we see that sometimes we do not see this airway closure and then airway opening pressure on the global curve, but we see it in one lung versus the other, for instance. So my guess is that we will talk about that more and more in the future. So thank you for the question, Michel. It's an important point to make the measurements very accurate.
Any more questions from the audience? There's one over there. While the microphones are going over there, a very quick one from me. So recruitability changes over time in patients, right, when the disease process changes, similarly to the previous discussion. So how will that impact?
Sure. Yeah. So as I said, the limitation of this technique is that you need a passive patient, right? So as soon as you have started spontaneous breathing, that's much more difficult to do because you need a long expiration without breathing, and that's a limitation. In patients who are still deeply sedated, we repeat the measurements. I have to say, we had a number of cases where we repeated the measurement during the same day or even the other day. It was usually fairly consistent, but as soon as the patient is improving, it becomes difficult to do it. Yeah, sure.
Thank you. Question from there.
Thanks for the great talk, Georg Misting from Austria. You were talking about the reasonable or safe pressures for the recruitment maneuver. How would you determine what is reasonable or safe? Do you have any threshold, or would you use esophageal pressure? I'm thinking about Arthur Slatsky's trumpet player example. What is the safe airway pressure you can apply?
Yeah. Okay, that's a good point. So the trumpet player for us would be the obese patients.
Yeah.
And again, no confusion. The obese patients do not have a stiff chest wall. They have like a load on the chest wall. Okay, if you lie on the bed and you put the Handbook of Physiology plus the mechanical ventilation book by Martin Tobin, that's how. And it's interesting because it's creating decrease in lung volume and atelectasis, but it's a different mechanism than the lung injury. So you need to counteract this with positive pressure. And in these patients, I found the esophageal pressure really useful, I would say important, to know what's the level of pressure needed to counteract this load. So yes, I use for the lean patients, I would stay for now with the plateau pressure around maybe 28 centimeters of water as my safety limit. But I will also look at the driving pressure, I will look at the PCO2, and I will look at the blood pressure to take the decision. And of course, if Marcelo is in my back, maybe I will have to go a bit higher, but I will be careful around these zones.
Thank you very much, Laurent. And we can move on with Michel Slama from the Group Hospitalier Sud from Amiens, France. We talk about the cardiovascular effects of lung recruitment, which is at the other side of the coin. Thank you.
Thank you, Paolo, for this nice introduction. So as you know, I don't have any conflict of interest, and as it was well demonstrated by the famous previous speakers, so to improve the oxygenation in ARDS, we need to open the lung. And what's using to open the lung? Maybe trying to use the recruitment maneuver. And of course, you all know this paper, which demonstrates that if you do a recruitment maneuver, you may increase the P on F ratio, the PaO2, and you may decrease the tissue which is not aerated. But the problem is that, and it was pointed out a lot of time ago by Warren Zappel in 1977, the work load imposed upon the right ventricle by elevation of the pulmonary vascular resistance may be a factor limiting the survival in severe acute respiratory failure. And many papers and from Antoine de Herbaron team demonstrated that with the mechanical ventilation, you may induce in ARDS patient an acute cor-pulmonale. And we just demonstrated in 677 patients, it's a multicentric study that we did with Antoine in COVID patients, that having an acute cor-pulmonale in COVID-19 patients increase the mortality by 2 times. So it means that if you do well for the lung, you shouldn't have an acute cor-pulmonale associated with any settings of your machine. And so, of course, everybody knows this ART study from Marcello, and we understood that the mortality may be increased if you do a strong maneuver and followed by titration of PEEP. But if you look at the findings, in fact, one of the main factors explaining this increased mortality in my mind is that there are sometimes bad hemodynamics during this maneuver and when we set a high PEEP. And you see that the ratio is 6.5. And so if you look at what happens when you do a recruitment maneuver, you see that if you do an abrupt, brutal maneuver, putting 40 centimeters of water during 10 seconds, you will have an incredible dramatic decrease of the size of the left ventricle as well as the ejection fraction. Here it was the fractional area contraction assessed by the short axis view of the left ventricle using echo. But if you do a very slow recruitment maneuver, maybe it's better for the hemodynamics. As you can see in this study, when you do this slow recruitment maneuver, the mean arterial pressure and the cardiac output did not drop a lot. And if you have as well an hypovolemia, so the effect of on the hemodynamics will be worse. And you see here that if you have a normal volemia, so the drop in cardiac output is less, and if you start by giving a fluid, so you have almost no drop of the cardiac output. And so we did a few studies with this maneuver, with the recruitment maneuver proposed by Marcello Amato, with the titration of PEEP, and then with the Sherry Eldash, we demonstrated that during the recruitment maneuver, so the size of the right ventricle increase and the size of the left ventricle increase, so the ratio is increasing during the recruitment maneuver. But at the end, when we opened the lung and when we set the best PEEP, which was 20 in comparison with the baseline value of 10, so we had exactly the same size of the left ventricle and the right ventricle. It means that maybe we opened the lung, and even by putting a high PEEP, we didn't have any effect on the right and left ventricle. And it's exactly the same if you assess the systolic function of the left ventricle by measuring the TAPSE, the movement of the tricuspid annulus during systole. You see that during the maneuver, so you have a drop of this systolic function of the right ventricle, but when we compare the baseline value and the TAPSE at 20 centimeters of water, which was the medial best PEEP, you see that you have exactly the same right ventricular function, and it's exactly the same for the cardiac output. No effect of decreased cardiac output by setting a high PEEP after opening the lung. And so we did another study, including 20 patients with moderate or severe ARDS, and again we found the same findings. It means that during the recruitment maneuver, we had a dramatic increase of the right ventricle and decrease of the left ventricle. But when we set the PEEP, the best PEEP, we got even a better ratio with a lower right ventricular size. And if you look again at the TAPSE in this second study, it was exactly the same that what we demonstrated with Sherry Eldash in the previous study. But which was very interesting is that we assessed during the recruitment maneuver and at the best PEEP, not only the size of the left ventricle, but a precise measurement of the contractility of the left and the right ventricle by using the speckle tracking method to assess the strain of the left and the right ventricle. And if you look at the right longitudinal strain on the right-hand side of the slide, you see that you have an dramatic impairment of the contractility of the right ventricle during the recruitment maneuver, and moving back, returning to the baseline value for the best PEEP. But which was the surprise is to see that not only the right ventricular functions was impaired, but as well the left ventricular function, the contractility of the left ventricle was impaired during the recruitment maneuver, but returning to the baseline value when we set the best PEEP. So what we tried to do is to do two groups. So one group who responds in terms of P on F ratio to the recruitment maneuver, and the second one, which were non-responder patients, in which the P on F ratio did not increase. And we got 10 patients in each group. And what happens? We demonstrate in this study that in non-responder patients, so the drop in cardiac output was really high. In contrast with responders, in which the P on F ratio increased by more than 50%, the cardiac output almost did not decrease during the recruitment maneuver. And if you look at this study as well, comparing poor hemodynamic tolerance during a recruitment maneuver and a good tolerance, you see that the only point which is different is the compliance between the two groups, and the compliance was much better in the group with a good tolerance. And this is a beautiful study performed in animals. They create and lobar atelectasis, and they did two different recruitment maneuvers, one global one and one selective one on this part, which had a lobar atelectasis. And if you look at the cardiac output dramatically decreased when they apply a global recruitment maneuver. But in contrast, when they did just a selective recruitment maneuver, they didn't have any change of the cardiac output. And then that's why we did with Johan Zerbib and Clément Brault this study. And in 30 patients with a COVID-19 related ARDS, we measured, as Laurent Brochard and Chen proposed, we measured the R/I ratio, and we got a cutoff value with a medial of 0.62, and we divided the patient in the ratio above and lower than 0.62. And then we did a stepwise low recruitment maneuver, and we assess the PA-on-F ratio and the compliance of the lung and the respiratory system. And we got in both groups an increased P-on-F ratio. But now, if you look with attention, you see that in the group, in patient in which we had a ratio above 0.62, so we got an increase in the compliance, respiratory compliance, in contrast with the group in which we had low lung recruitability. But which was very interesting is that when we assess the hemodynamic, for example, with the pulse pressure, so the pulse pressure did not change in a patient with a high lung recruitability, but decreased dramatically when the patient had a low recruitability with a ratio below 0.62. So which are our explanation? Our explanation is that in a non-responder patient, when you increase the pressure, you have a part of the lung which is closed, and you have the baby lung, and the baby lung during inflation, so induce an overinflation of the lung and doing compression of the pulmonary capillaries, inducing an acute cor pulmonale. And in this case, because the patients are not responders, so it means that the over-distension remains at the high level and still compressing the capillaries and inducing an acute cor pulmonale, which is, again, a very bad thing because increasing the mortality of patients with ARDS. In contrast, in responders, our hypothesis is that when you open the lung, of course, by putting a high pressure, and when you go back to a pressure of 20, for example, so you open the lung, and at that time you have no over-distension of the lung, and you have no compression of the pulmonary capillaries, and then you have no pulmonary hypertension and no acute cor pulmonale. So to conclude, in ARDS, despite a recruitment maneuver dramatically increased P-on-F ratio, this maneuver may be deleterious and may induce acute cor pulmonale, hemodynamic instability, left and right dysfunction. But stepwise slow maneuver seems to be to have a better tolerance than other method. Hypovolemia should be avoided before performing any recruitment maneuver. And we use now the R to I ratio to predict if this recruitment maneuver will open the lung or not. And this ratio not only tell you that the lung is recruitable, but is also associated with a better hemodynamic tolerance during the recruitment maneuver and when you set an high PEEP on the lung. Thank you very much for your attention.
Thank you, Michel. We have just 2 minutes for discussion. Any questions? Yes, Marcelo?
Thank you, Michel. This was wonderful. It in fact is much more a comment. Isn't intriguing to see that in the old physiology times, people had a completely in contrary concept that any hemodynamic consequences would be lower in patients with low compliance because then you would not squeeze the heart and the pleural space. But here, when we focus on the right ventricle, it's completely the opposite, right? So it was very well demonstrated. I like it very much. Thank you.
Thank you for this comment, Marcello.
A very quick question. So in COVID-19 ARDS, there's sort of an interesting pathophysiology with lots of microthrombi in the pulmonary vasculature and PEs, which causes a very unhappy right ventricle in a proportion of patients. How is that going to influence the things that you've shown us? Because, you know, when perfusion itself is very sick, how is that going to influence the things that you've shown us?
Thank you. Yes, thank you for this question. You are right that maybe the physiology of COVID-19 infection at the early phase is really different. But most of the time in the study that we performed with Johan Zerbib and Clément Brault, the patients were under mechanical ventilation for a long time, and they had classical ARDS, and we demonstrated that. We did a paper with them to demonstrate that at that time it's exactly the same as the classical. But I agree with you that we didn't take into account the problem about the pulmonary embolism and the effects that may change the findings regarding the studies that we did. So really, at that time, I don't have any answer regarding the influence of this micro thrombi that we found during, for example, different autopsies that we did. I don't know if it may change the findings that we got. Don't know.
Thank you, Michel, and we can close the session. We thank all the speakers and we leave the stage for the poster award ceremony. Thank you.